It's actually sunny here today in the UK.
Oh, it's nice then.
Yeah.
Yeah.
No rain
Oh.
today.
And I've just realized that Finami already gone back to
Absolutely,
Surakarta.
yes.
So
Yes.
yeah,
But now is in
just realized
Surakarta.
that 2 days ago. So you must be missing all of us, Linda.
I am. I really am. I've got to get back somehow. when the pandemic allows, I'll be on the first plane to Indonesia.
Yeah, and also the program that I've told to you before when we spoke together with Andari. I remember it's the international student mobility.
Oh,
so,
yes.
If the University of Leeds send the proposal to the Ministry of Education, then it allows all students from all over Indonesia, not only from the UNISA, to come to University of Leeds. So yeah, next year we have to apply for that.
Yeah, we do. I've already spoke to Professor Hurst, head of school, about this, and she's keen. And I've spoke to the new Prodean International, Peru, and alerted him. And UMS have already contacted him about it as well. So it's very likely Leeds will put in an application. So you need to brief me ahead, and I will push it. I will push on our side. I will not push. It's not the right word. I will engage the right people. On the University of Leeds to get it going.
Yeah.
But I have already alerted people that we're interested.
Yeah. So the program will open not only for the UNISA student, but also from any universities in Indonesia, whether it's the University of Indonesia, Gajah Mada University, to study for 6 months at the University of Leeds, maybe at the School of Healthcare, for doing the undergrad program or master program. So yeah.
Well, I'm still linked to the Deputy Vice Chancellor, who was for International, Hai Sui, has asked me to do some strategic work with him, Chaser. So it's a great opportunity to showcase our partnerships with Indonesia. So I'm using every opportunity as usual.
Yeah.
But yeah, I'm doing some work with him next week, actually, on the Wednesday, after we've had the International Day of the Midwife event. So there's lots of opportunities going forward, I think.
Yes. Okay. So Linda and Debbie, because the Zoom is not, well, we also stream the Zoom to the YouTube for the undergraduate students who cannot be accommodated to this Zoom link. So some of the students also can access this online streaming from YouTube.
Okay.
That's great, yeah.
Mrs. Usi?
Halo Bu Cesa.
Ya. Oh.
Hello.
Hello.
Are you well? Are you well, Fitria?
Yes.
Good, good.
Very good.
Nice to see you.
Nice to see you too, Linda.
Okay. I'll make Razania as the co-host. Okay. Mrs. Usi, can you already speak now?
Yeah.
Okay, that's good.
Is that clear enough?
Yeah.
Yes.
So before we start, just like yesterday planned, so we are going to introduce Professor Linda McGowan first, and then she's going to open the session and then explaining about the collaboration between UNISA Yogyakarta and the University of Leeds. And then later then we can also continue to introduce Debbie's CV, and we can start to Debbie's session. Sure. And
Chasey, you don't want me to do the introduction for Debbie, you will do it.
all
You've
right
got the
then.
CV. Is that the plan? Is that the plan? Yeah.
Yeah,
You might
yeah,
make it simpler. Yeah. Okay.
All right then.
I'll talk about the partnership and then hand back to you to introduce Debbie.
Or otherwise, yeah, you can also straightforward to introduce
Okay.
Debbie if you would like.
Yeah, I've got a few words. Yes.
Okay.
Yeah. Okay.
Bu Ika, Bu Aisyah, Bu Dika, shall we start, Ibu?
Ya,
Yeah,
silakan Bu Cesa.
Okay. Bu Ika, are you going to give some opening first? Or Ibu Dika?
Bu Dika, Bu.
Oh, Bu Dika, oke.
Saya Miss.
Oke, then. Ya, silakan Bu Si. Bisa dimulai, Bu Si. Monggo.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning to Ibu Linda and Ibu Debbie, and good afternoon, ladies and gentlemen. My name is Lucy. It is a wonderful and precious chance for me to be your Master of Ceremony in our event Stadium General of Physical Therapy program. I would like to extend a very warm welcome to all of you. We appreciate you taking time off your busy schedules to join us today. First of all, let's say thanks to Allah Subhanahu wa Ta'ala, who has been giving us guidance, happiness, healthy, and mercy, so we can attend and participate in this event without any obstacles. Praise and salutation upon our Prophet Muhammad Sallallahu Alaihi Wasallam, the best figure of this universe, the person who was able to save us from Jahiliyah era. In this beautiful moment, I would like to welcome Ibu Professor Linda McGowan and Ibu Dr. Deborah Antcliff, PhD, who will be the speaker at our event today. The Honorable Ibu Dika Rizky Imania, Magister of Physiology, the Honorable Ibu Umi Aisyah, Magister of Physiology, the Honorable Ibu Ika Fitri Wulandari, Magister Ergonomi, and welcome to all participants of the Stadium General today. On this special morning, we have several agenda as follows. The first is opening. The second is greeting. The first greeting will be delivered by the head of physical therapy program, and then the second greeting will be delivered by Ibu Professor Linda McGowan, and then the third is main lecture from Ibu Dr. Deborah Antcliff, PhD, and then the fourth or the last is closing. Ladies and gentlemen, before we start our Stadium General today, let us pray together by saying Basmalah. May Allah Subhanahu wa Ta'ala make this event beneficial for us, and this event can run smoothly and convincingly. To begin this Stadium General, we are pleased to have Ibu Dika Rizky Imania, Magister of Physiology, as a head of physical therapy program to deliver the opening remarks. Please.
Well, thank you for the time, Miss Usi. Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. The Honorable Head of International Office and Partnership Universitas Aisyah Yogyakarta, Ms. Cesa Septiana Pratiwi, PhD. The Honorable Secretary of Physioterapi Department, Ms. Umi Aisyah Nurhayati and Ika Fitri Wulandari. The Honorable Prof. Linda from University of Leeds. The Honorable Dr. Deborah Antcliff, PhD from University of Leeds. The Honorable Lecturer and Clinical Educators, University Asia of Yogyakarta, and all participants, the physiotherapy students who I respect and are proud of. First of all, let us praise and thank the presence of Allah Almighty for the abundance of grace of the joy of all. Us can still gather in virtual conference without any barriers at all and good health. Not forgetting the salawat and greetings we brought out to the Prophet Muhammad Sallallahu Alaihi Wasallam, who has brought us out of the dark ages to the era of bright light today, namely Islam. May we all get intercession of the end. Amin. On behalf of Head of Fisioterapi Department Universitas Aisyah of Yogyakarta, I feel grateful and thankful our speakers, Dr. Deborah Antcliff, PhD, who would convey the topic related which really benefit for our students. In today's Studium General, we would learn about introduction of physiotherapy practice in the United Kingdom and activity pacing for the management of persistent pain or fatigue. Last but not least, our appreciation also goes to the students who have taken the time to participate in this activity. Finally, congratulations following the virtual conference. I sincerely hope you enjoy this conference until the end of the session. I also hope this conference will give positive contribution for physiotherapy development in the world. Okay, thank you. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Ibu Dika, for the wonderful remarks. Before we continue our studying journal today, I'll remind all of the participants to mute the microphone in order to avoid any interruption. And then please turn on the camera during the studying journal and later fill out the attendance list. Okay. And then the second, we are pleased to have Ibu Professor Linda McGowan to deliver the speech. Before we start, I'll share the CV first. Oh, okay. Okay, I'll introduce Ibu Professor Linda first. Her former position is Prodean for International Faculty of Medicine and Health, University of Leeds, and then now she is Chair for Internationalization School of Healthcare, and then she is a Professor of Applied Health Research in the School of Healthcare. Her main research interests include all aspects of women's health with a special focus on maternal health and well-being and midwifery research. She has a clinical background in nursing and midwifery and a PhD in health psychology. Ibu Linda is currently appointed as a visiting professor at Universitas Aisyah Yogyakarta since 2017. So please welcome.
Thank you. Do you want me to start? Yes? Okay. Thank you very much for your warm welcome. I'm delighted to be involved in this event today. And this is built on the partnership that we've been building for several years with UNISA University. And particularly I was linked with the Masters of Midwifery program to start off with. And then because Dr. Chaser and Dr. Andari are alumni of Leeds, we've really built a very solid partnership to build on. And it's supported by the School of Healthcare, Head of School, Professor Janet Hurst, and by your rector, Mrs. Wasiti, who's been very supportive of the of developing the partnership. And I see it now because we've just renewed the MOU between School of Healthcare, University of Leeds and UNISA to build in other areas, and this is one of them. So to help sort of develop and support your other programs. So I'm delighted today that to introduce you to Dr. Debbie Antcliff, to your physiotherapy program, and I'm delighted that students are joining the session. So welcome. Just a little bit about Debbie is, I've got a few notes here just to say that Debbie qualified as a physiotherapist in 2002. She has a specialism in the management of persistent pain and fatigue. She was based at a local trust in Bury, working on an integrated pain service. I had the honour of meeting Debbie when she was doing a PhD and was an advisor on Debbie's PhD. She then went on to get a very prestigious fellowship in the UK, which is from the Department of Health, the National Institute of Health Research. And she successfully completed a postdoctoral fellowship. And she's now got another fellowship where she's looking at trials. She's working with the University of Kiel and the University of Leeds to look at how best we can develop and design clinical trials. Debbie is one of the leading physiotherapists in the UK in terms of research in pain management and fatigue. So I'm very happy to pass the floor to Dr. Debbie Antcliff. Thank you.
Thank you for Professor Linda McGowan for the wonderful speech and for the introduce Ibu Debbie to us. Okay. Okay, now we are all geared up for our study on journal today. I hope all of you can pay your attention to all the materials throughout this session and put your question at the end of the presentation in the Zoom chat box, or drop your comment in YouTube, or you can directly ask Ibu Devi. Okay, hi, Ibu Devi, good morning. How are you?
Good morning. Thank you so much, everyone, for, as Linda said, the warm welcome, and thank you, Linda, for the introduction. It's a great privilege to be able to speak with you all today, and I remain in awe of the technology that connects us across the miles. So I'll be hoping that technology keeps working.
Okay, since this is COVID-19
Shall I start?
Yeah.
We just can meet you by Zoom.
Absolutely, yes.
Oh, lovely. Well, I'll try to share my screen. I'll bring up my slides, but please wave at me or shout at me if you can't see anything moving. Okay.
Before we start, Ibu Devi, we will have about 80 minutes for this session. You have about 15 minutes for presentation, and in the last 30 minutes, we will have a Q&A session. Is that all right?
Okay, that sounds great.
Okay. For our study in general proper, may we call on our speaker for today? Please.
Okay, I'm hoping, can you see my slides okay?
Yeah.
Yeah, lovely. Again, thank you so much for this honour of speaking with you. I'd like to talk through my experience of being a physiotherapist in the UK. I'm a clinical academic, and what that involves is a split role. So I undertake both clinical duties as a physiotherapist and also research. And my field of interest is in behavioural change, or instructing coping strategies So what we want really is to instruct our patients to be able to best manage their long-term condition of pain and fatigue. What I'd like to talk about this morning is being a physiotherapy clinical academic in the UK, to give some background to conditions of chronic pain and fatigue, to give some background to my research in the field of activity pacing as a coping strategy, to discuss some of the successes and challenges I've had during my research journey, and also to talk about my future planned research. Within the UK, physiotherapy, and you come out with a Bachelor of Science, and this usually takes 3 years on a full-time basis. And similarly to yourselves, we undertake modules on anatomy, physiology, kinesiology, the study of movement, across fields of different medical conditions and pathologies in musculoskeletal health, cardiorespiratory, and neurology. And we also include approximately 1,000 clinical hours on placement during our training. And the image on the right of the slide is the University of Manchester, and this is where I undertook my degree in physiotherapy. As Linda joked before, it's uncommon that it's sunny in the north of England, but this is a good picture of a sunny day. On qualifying as a physiotherapist, you're encouraged to register with some professional bodies. The Health and Care Professions Council, the HCPC, is open for all different healthcare professionals, and they're really a regulating body to check that your training fulfills the role that you need to be undertaking. We also have a chartership, the Chartered Society of Physiotherapy, and this provides a trade union, so it gives you some access to legal support. But the Chartered Society of Physiotherapy is also a really great society for opportunities for training, for your portfolio and your skills up to date, for research conferences, and also the provision of small grants. And within the use of physiotherapists, and we call these rotational physios, and often they rotate between different departments of musculoskeletal, orthopedics, respiratory, to really gain those on-the-job skills. We then try to become more senior in our role as a Band 6 physiotherapist, to then a specialised physiotherapist as a Band 7, and then as an advanced physiotherapy practitioner as a Band 8A. There's many opportunities as a physiotherapist in the UK, and one of the biggest employers of physiotherapists is the National Health Service, the NHS. And within the NHS, we have primary and secondary care. Primary care is that first person that you see when you're unwell, so it could be a general practitioner or a physician. And there's a growing number of jobs and encouragement towards first contact practitioner roles for physiotherapy. So instead of seeing a GP, a general practitioner, you might see a physiotherapy first off if your medical condition seems to be predominantly musculoskeletal. There's also many opportunities within secondary care, and this includes inpatients, so in patients that are based in hospital wards or outpatients in different departments: general medicine, oncology, musculoskeletal, women's health, community physiotherapy, paediatrics, and also pain, and persistent pain is where I'm based. And separate to the government-led National Health Service, we also have private healthcare, and we have private hospitals who also provide physiotherapy, private businesses or private physiotherapy clinics, and also opportunities as a sports physiotherapy in professional or semi-professional teams, and also the military of defence. So really, there are a wide range of opportunities to be a physiotherapist here. For my own personal development as a clinical, I needed to develop my clinical role, and I transitioned through the rotations as a junior physiotherapist and soon recognised that my personal interest was in the musculoskeletal department. Within that department, we saw an awful lot of people with persistent conditions, especially chronic low back pain. And my interest in the complexities of chronic pain really grew from there towards now, today, when I'm an advanced physiotherapy practitioner within a specialised pain service. The image on the right shows our pain service, and within this team, we provide holistic assessments. And what we mean by that is a truly biopsychosocial assessment with patients with chronic pain and fatigue. And we also then deliver holistic treatments. So we either treat patients on a one-to-one basis or as a group in a pain management programme. And with these patients, we really want to be talking about coping strategies, things like goal setting, graded exercise, graded activity, activity pacing, using mindfulness and relaxation, some of those psychotherapeutic approaches, and also medication reviews. And again, the medication is a really exciting opportunity for physiotherapists. There's growing courses for non-medical prescribers. And actually our role in being able to talk to patients about medication is really important, especially in the field of chronic pain. In the UK, similar to the USA, we have a problem of patients using high dose of medication, including opioids, things like codeine and morphine-based medications. And actually, it's really important that we feel qualified and able to talk to patients about some of the harms and risks about taking high-dose opioids. I also developed my role as a researcher, and this began in 2010 at the University of Manchester when I started my PhD. This for me was a fantastic opportunity. I was able to continue part-time clinical duties whilst undertaking a PhD. And it took me through 6 years on this part-time basis. And the PhD involved specific training in research skills, understanding research methods, also involved me undertaking my own research project. And from that project, I needed to write up a thesis, a very large document, but then also to disseminate my findings as more readable paper journals. At this stage, I was also applying for small grants. I applied to the Chartered Society of Physiotherapy for a small grant that enabled me to travel, and I travelled to Vienna in Austria, Europe, and was able to present my PhD findings. I also applied to our R&D, the Research and Development Department in the Northwest, and I was awarded a small amount of money to undertake some patient and public involvement work. And what we know about patient and public involvement, PPI, is really crucial to involve patients within the planning of research, but also the undertaking of a research project. My role as a researcher continued to develop in my postdoctoral fellowship, and this was awarded by the National Institute for Health Research, and this was called a clinical lectureship. And this saw my move from the University of Manchester to the University of Leeds, working under the direct mentorship of Professor Linda McGowan. For me, again, this was the ideal job. I was able to continue 50% of my role as a physiotherapist working with patients and 50% as a researcher. For me, this mix is superb. It means that I see patients, I get to hear about real life conditions, real life challenges, and then implement those real life stories into research. Similarly, I undertake research so I can deliver that back to patients and say, well, actually, we implement this treatment because the research says this is the best way to manage this condition. To give a background about chronic pain and fatigue, which forms really the underpinning of my research, we know that chronic pain affects between 1/3 and 1/2 of adults in the UK. And chronic low back pain is the leading cause of disability globally. Within our pain, we also see other commonly presented conditions, including chronic widespread pain, and this refers to multi-sited pain, Within that umbrella term, we often see people with that diagnosis of fibromyalgia. We also see people with chronic neck pain and also chronic fatigue syndrome, myalgic encephalomyelitis, or CFSME. Those conditions share many commonly presented symptoms, fatigue, but also sleep disturbance, reduced quality of life. We know that these conditions coexist and they also overlap. And many of our patients will say, yes, I've been referred to you with chronic low back pain, but actually I also have neck pain, I have widespread pain, and I feel very fatigued. The International Association for the Study of Pain more recently updated their definition of chronic pain, and it's been defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And within that definition, there's some really important key points. Chronic pain is defined as pain lasting for over 3 months. At this stage, we assume the tissue healing process is now complete. Chronic pain is also multifactorial. It involves biological, psychological, and social processes. It's useful to compare the differences between acute and chronic pain. With acute pain, we know that this is the pain that occurs within the first 6 weeks of injury. At this point, it might be described by a patient as sharp, stabbing, a sudden pain. We also call pain that's lasted between 6 weeks and 3 months subacute. And during this period of time, there's a tissue healing process occurring. So this is when someone sustains an injury, there's a warning sign that there's some damage to tissue and the healing process commences. And this pain we tend to call adaptive because of this warning sign. It tells us that something's happened. We call it protective and purposeful for that reason. An example of an acute pain would be accidentally picking up something really hot, something that's just come out of the oven. You get that sudden sensation of pain. There's a warning signal that reaches the brain that tells us to respond, and we tend to respond with movement and we put that hot item down. We need that warning sign to tell us that there's damage. Otherwise, we'd keep hold of that hot item, we would burn ourselves, we would damage layers of soft tissue. So it's really important that we know that that's that warning sign. If we compare then with chronic pain has been there for over 3 months. Patients describe it as dull, aching, but in addition to that, they describe it as being tiring. It's a mental health element. We know at 3 months, the tissue healing process has been completed. So we wonder why we're still getting that warning signal. And we might consider chronic pain to then be maladaptive. Is it still warning us of danger? Is it protecting us anymore? And does it have a purpose? And often with patients, when I see them and they're reporting pain and they feel they're in danger, we often say, are you in pain now? And they'll say, yes, I have my pain now. But we say, well, you're sitting, we know you're safe, you're not in any harm. You're in a clinical practice, you're in a healthcare service, surrounded by healthcare professionals. You are safe, but for some reason, your body is giving you these warning signals. Chronic pain is subjective. It's dependent on every individual person's experience. So it's individualized, but it's also very real, and it should always be respected. What's very important to remember is all pain is the output from the brain's processing. So if we think again to picking up that hot object, it's not that we feel pain in the hand. What we feel in the pain is a sudden change of temperature. And on all of our body tissues, externally and internally, we have sensors. And these sensors are always looking for a change in temperature, extreme hot or cold, a change in mechanical pressure, so a compression, for example, say if we trap our finger in the door. They're also looking for any change in chemical imbalance. So say if we spilt bleach on our hands or we got shampoo in our eye. Now those mechanical, temperature or chemical stimuli, those stimuli will travel to the brain via nerve responses. The brain will recognize whether that stimulus reaches a threshold. If that threshold is met, the output is pain, and then the brain will send a downwards message for a response. So all pain is made in the brain, but that's it's made up. And that's a very difficult message to explain to patients. And again, we go back to that second point that all pain is real. It is individualized, but it's also very complex. Because the brain is involved in processing our experiences, those changes in stimuli, it's also doing other things at the same time. Within the brain, it's going to be referring us back to our beliefs. What do we think is going on in the body at that time? And if it is that we believe that there is some serious damage, our pain response is going to be higher. And in the pain literature, there's a very old story, but it's brilliant. So I'm going to use it to explain why what we believe is so important. There was a gentleman, and he was working on a construction site, and he jumped from a higher level of scaffolding down below. And when he landed and he looked down, there was a big, rusty, horrible nail that had gone right through his boot, and he could see it the other side of his boot. He assumed that he had stood on this nail, it'd gone through his foot, and he panicked and he started shouting, and his pain experience was very high. His colleagues had to lift him into an ambulance. He got taken to a hospital. The boot was still on, the nail was still going through the boot, and he was in agony, and his pain was very real, very excruciating. He was shouting the whole time that the surgeons carefully removed his boot. Once the boot came off, they realised the nail had gone right between his two toes. There was absolutely no tissue damage. The man was safe. There was no harm. But because the man had seen the nail, he believed he'd harmed himself. His pain experience was very high. So beliefs are so important. Memory is also important for pain. We will often go back to a place if we've been there before. What does this remind us of? How did we cope with it last time? I have a work colleague who has an awful fear of dentists, as many of us do. And years ago, she had an awful toothache. She had a dental abscess. And she needed surgery to resolve that anymore. The tooth's gone. But now when she goes back to the dentist, she walks through the door, she smells the dentist, she can hear the sound of the dentist, she sees the dentist, and she gets that pain again because she has a memory for pain. We also learn. We learn many things. We learn different languages. We learn our anatomy. The brain is always adapting, but it learns about pain as well. And great examples are when we watch children play and we see them running around and they're fine, they're happy until they trip over. And they'll look to their parents and they'll see what their parents' response is. If the parents look horrified and they run over and they really pay the child an awful lot of attention and think, oh my darling, you must be hurt, the child might remember that and next time might respond in a similar way to get a little bit of attention and possibly a treat. The context is also really important. The way we feel pain varies. On a day where in a place that we feel happy, we're surrounded by family, it's sunny outside, our pain experience is probably going to be lower than a day that we feel isolated, we're on our own, we're in a place that we don't like, and it's raining outside. The amount of attention we give pain is also going to affect our pain experience. The more attention we give the pain, the more the brain has to work with, so the output's going to be greater. And we can often think about that in terms of, now if we try a little experiment, I want you to, as you're sitting or standing listening, have a think about your own body. And I'm going to start off at my feet. And I'm going to work up from my feet, and I'm just going to look for any pain anywhere in my feet or my legs. I think my feet and my legs are okay. But as I come up my back and my neck, there it is. There's a twinge there, I found one. So actually you can search your body and you can start thinking of sensations, but then my attention will move on to the next slide. So actually that neck pain won't be my biggest issue. Our mood is also really important, and there's been an awful lot of literature to show that anxiety, depression, our mental well-being is directly correlated to our pain experience. The reverse is true. So how much pain we're in is also going to affect our mental health. It's very hard to be light-hearted and carefree if we're living with a lot of pain. But pain doesn't always equal harm. Again, pain is very complex. On here we have a diagram. So across the x-axis is increasing tissue damage. Across the y-axis, the vertical axis, is increasing pain. It would make sense if pain was this straight red line. So the more tissue damage we did, the more pain we were in. However, that's not the case. And where you see the blue star, we can see this is a place where there's high tissue damage, but actually fairly low pain reports. And examples might be soldiers at war. They're on the battlefield, and we know that many sustain horrendous injuries. But in the context of being on that battlefield, the pain isn't their biggest issue. Their biggest issue is possibly saving their comrade who's also fallen. It might be running to a safety point. So they probably aren't expressing their pain at that moment. If we look here though, at the red star, now this is a case where the tissue damage is low, but the pain experience is very high. And a really great example would be a paper cut. And I don't know if anyone sustained one in the last week. I have, and it was really painful. It took me by surprise, and then I forgot about it. And then later in the evening, I squeezed a lemon over my dinner while I was cooking, and then it was even more painful. And so my pain reports was quite high, but the tissue damage was very low. It was superficial. It healed within a day. Other examples of when pain and tissue damage don't always match, are arthritic changes, say in a knee joint. We know that many people see us and they have high reports of pain, and so we x-ray their knee, and actually there's not much arthritic change within the knee, and so we don't recommend surgery because we know we can't surgically remove pain. We need a surgical target. We also know there's people who have high or very marked arthritic changes in the knee joints, but their pain reports are actually very low. The same has been found with degenerative spinal changes or age-related disc disease. We know now that about 50% of 40-year-olds will have evidence of a disc bulge. Of those people, some will have pain and some won't. We know that we can live very well with arthritis and bulging discs or a prolapsed disc. It may or may not cause us symptoms. So we always need to know whether the pain is matching the symptoms before we go down the route of surgery or anything interventional. Phantom limb pain is maybe a phenomenon that you've heard of before. This is an example where someone who perhaps has been living with a very painful area, for example, a foot, for many years. And we see people with vascular problems and they suffer with ischemic pain, and they maybe have a very necrosed area of the body. and that limb or that body part might be amputated in surgery. When they wake up from surgery, that person says, oh, my foot really hurts, or my foot's itchy, can someone just touch it for me? They might even believe that limb is still there so strongly that they try and stand up and stand on it and fall. And this is because, again, the brain's learnt that the foot is usually there. The brain has mapped out all of our body parts. And so when something's suddenly missing, the brain still thinks it's there. So again, pain doesn't always directly link with harm. We know there's great effects from the placebo and nocebo effects. So if we think about randomized controlled trials of medicines, and we have a tablet, and we give a tablet to a person in the trial, and we say, this tablet will make you feel absolutely amazing. This will make you feel 20 years younger if you take it. The person might take it and feel amazing, but they might have had the placebo tablet, just the sugary tablets. But again, they believe that they've had something that's so effective that then their pain and their symptoms reduce. The opposite to this is the nocebo effect, where we say, this treatment's going to do nothing, absolutely not going to help at all. And invariably, the patient will believe you. With chronic pain, from the research, we know there's this process of central sensitization, and this helps us to understand why pain is so complex. If we think about a car alarm, it's a warning system. We want the car alarm to go off if someone smashes the window and tries to steal our car. That's helpful. We need that warning system. What we don't want, though, is the car alarm to go off if the wind blows or if someone just walks past our car. The car alarm will go off all the time. And similarly, this is what's happening with chronic pain. We need our bodies to feel pain to keep us alive, to keep us safe, to keep us from not holding on to that really hot thing that's going to keep burning our tissues. But what we don't want is this upgrading of the nervous system. And this is what's happening with chronic pain, central sensitization. The nervous system has gone into a warning zone all of the time. And patients say, yeah, why is it that something nice like human touch, like a hug, now feels painful? Why is it that the weight of my duvet feels painful? I know that's not dangerous. We talk with patients about chronic pain and fatigue in a cycle, and unfortunately, it can become a bit of a vicious cycle. We see patients at the start with pain and fatigue, and the natural instinct for any human is if something hurts, well, I don't want to do it. So they reduce their activity. They avoid the thing that causes them pain. Over time, when we withdraw from activity, we lose our muscle strength and we lose flexibility. For example, those people on ICU, we see them lose vast proportions of muscle bulk and muscle strength even after a week of bed rest on ICU. When we reduce our strength and our flexibility, it actually increases our pain and fatigue when we do try and do things, when we try to bend, when we try to lift or exercise. It's more difficult because we're deconditioned. So then we naturally do less. We reduce our activity even more. We think, well, that was painful. I don't want to do that again. When we reduce our activity, when we become more sedentary, possibly when we start sleeping in the day, it disturbs our sleep routine, our sleep hygiene, and it disturbs our bedtime sleep. We also know that pain disturbs sleep. So when we turn over naturally in the night, in those natural waves of sleep, if we have pain, that then wakes us up again. If we're not sleeping, if we're not doing the activities that we like doing, if we have pain, it's going to have an impact on our mental health. And again, you can see that pattern between pain and depression and anxiety. If it is that we've got worse mental health, our pain experience increases, and you can see how this vicious cycle is set up. And so part of our role as physiotherapists in the persistent pain service is to try and help patients to break this cycle. We know we can't just take away pain and fatigue. So what we try to do is think about the activity side, the strength and flexibility side, talk about sleep hygiene, managing mood. I'm also showing here the cognitive behavioural model, and this really involves cognitions, our thoughts, our emotions, and how that interacts with our behaviours. And so common thoughts and things that patients say to us with chronic pain: I'll never get better. I'll damage myself if I exercise. And if they've got those thoughts, they're likely to feel low in mood. They might feel worried about the future. How am I ever going to get my child to school? How am I going to keep working? They feel guilty because often other people in the house are doing their usual jobs for them. But then because they're having these thoughts of, I can't do this, I'll never get better, they also have behaviours of over-resting and avoiding activities. And fear avoidance is a real problem that we see people presenting with. They're fearful of pain, fearful of injury or re-injury. And we could start at any point in that triangle and move in any direction. So those thoughts, emotions, and behaviours are interrelated. And this brings on the background to activity pacing. So we've said pain is complex. We also can't cure chronic pain. We can't just stop chronic pain and take it away. We'd love to be able to do that with patients. But because we can't cure it, what we do instead is try to give patients a toolkit to best manage their condition. And this comes in the form of coping strategies. And activity pacing is one of our most frequently talked about coping strategies. And not just physiotherapists mention it, often occupational therapists, pain specialists, nurses, doctors. And we often say, oh, well, pace your activities and that will help you to manage your condition. Not only is pacing described as a coping strategy, but it's described also as a behaviour, so your approach to undertaking activities. And pacing might be best explained in the context of perhaps some unhelpful behaviours that we see patients presenting with. And you might have heard of this boom-bust cycle with patients. And on this chart, we have time, a period of time running across the x-axis or the vertical axis, and activity going up the vertical or the y-axis. And what we see, patients with long-term pain and fatigue, they might have a good day. And on that good day, they try to do all of their activity all in one go. They boom. They try to make up for lost time. They try to fulfill all the jobs they've not done. They clean all of their house. Unfortunately, that's often not sustainable. So then they crash. They have a bad day and they go bust, and their activity levels really fall. And on these days, they have to recover. They pull back. They wait for a good day again, and then off they go, they boom again. So you can see this roller coaster of highs and lows of activity. It's not only highs and lows of activity though, it's highs and lows of mental well-being. On a good day, patients often say, I feel cured, I feel fine, I don't feel like I've got the condition, and it's quite addictive. However, on a bad day, patients report feeling very low, very demotivated, depressed, very anxious, cross with themselves, frustrated and angry. And you can see this patient isn't in control anymore. Their symptoms are in control of what they're doing. So now their medical condition is governing their activities. They have to wait for a good day and they do lots. And then on a bad day, they don't do much. We can also see that there's this gradual decline in activity over time. So those peaks and troughs all become a bit lower. Another pattern of activity we see is something we call excessive persistence or overactivity. And this is where someone works at a very high level. They're achieving lots, they're working very, very hard. They're being everything to everyone until they crash. They just can't do it anymore. They give themselves no time to recover and then they set off again. And we see patients who are perhaps very driven, type A personality patients, people who perhaps overwork in the week, and then there's just nothing left for themselves of their own pleasurable activities at the weekend. So again, quality of life isn't great here, and it's not sustainable. We see this gradual decline over time. Contrary to those other types of behaviours, we see an avoidance pattern predominated by underactivity. And this person might have been highly active to begin, sustains an injury or an accident or an onset of symptoms, and then has a decline in activity. They might attempt some activity, but then can't sustain it and then gradually decline further. In contrast, this is what we think activity pacing looks like. Activity pacing might start at a lower level, a baseline of activity where you're finding what's achievable across most days. There might be bumps in the road, and that's okay because that's normal life. We don't do the same thing every day. We don't feel the same every day. But there is that optimism for a gradual increase over time. We want to rehabilitate our patients to increase their confidence that they can do a little bit more than they are currently doing. And we hope that patients feel more in control. We've reduced those highs and lows of high and low activity. So pacing might be used as a standalone strategy, but it's also considered a key component of cognitive behavioural therapy, graded exercise therapy, and pain management programs. And what does pacing actually mean to the patient? What does it involve? If we start at the image on the top left of the screen, we see a hare and a tortoise. And you might be familiar with the old anecdote of the hare and the tortoise are in a race. And the hare runs around at a crazy speed, but then falls asleep because he's just overdone things. So perhaps the hare is part of that overactivity, that excessive persistence. Meanwhile, the tortoise, going slow and steady, keeping a really consistent speed, wins the race. So historically, pacing used to be considered to be all about going slow and steady. We actually probably think it's not so much about going slowly. We don't want to slow our patients down. We know already there's a lot of fear and a lot of avoidance. And actually, we know that when we move really slowly and we fight against gravity, it's harder work than just moving at a normal pace. So we don't think it's about going slow, but we do think perhaps that regulation is more important. Below the hare, you can see a decreasing arrow, and this represents perhaps that some patients need to do a little bit less. Those excessive persistence behaviours probably need reducing so people are a bit more consistent. So it might be about breaking down tasks, spreading out activities, switching activities. The mug to the right of the arrow, that demonstrates having a rest break, and pacing probably is about switching between activity and rest. But remembering a rest break doesn't mean a lie down, it doesn't mean a sleep, it might not even mean having a cup of tea, it could be switching activities. So from doing an activity in one position to then switching your position. There's an image of a gentleman holding onto his back in the bottom left corner. Now this back, it looks hot, it looks painful, it looks swollen, it's orange, it's got the warning signal. And this really represents whether we listen to our symptoms or whether we follow what we call symptom contingency. Should we pace and should we do our activities according to what our symptoms are telling us? Now this is confusing because we've just spent the last few slides telling us that our warning signals in chronic pain might be sending us too many messages. So is that always going to be helpful if we only ever listen to pain? If it is that we stopped an activity when we started our pain symptoms, we'd actually end up doing less. So we don't think symptom contingency in chronic conditions is our most helpful approach. It might be more helpful if we think about that timer, that stopwatch next door to that image of the man. Is it more helpful to do something according to a period of time or a goal or a distance? Is there something that we wanted to complete or at least attempt? Within that though, we don't want to be too rigid. We don't want to tell patients you must exercise for 30 minutes, then you must rest for 10 minutes, then you must do this for 20 minutes. Because that's not what life looks like. And it's too rigid, it's too prescriptive, and patients won't want to do that. Is pacing about scheduling things in a diary? Is it about mapping out, knowing that you have a busy day on Tuesday? So actually, what can you do to prepare on Monday? What do you need to do on Wednesday to recover? Is pacing about writing lists and prioritising? And we really encourage prioritising those meaningful and enjoyable tasks. Many patients with chronic pain spend their whole time doing those have to activities. I have to do the dishes, I have to cook, but we want them to also do the things that they enjoy, their hobbies, their socialising. Is pacing about hitting the same target every day? Is it about being consistent? And we think it is. We want to regulate those highs and lows of activity, the highs and lows of symptoms, and those highs and lows of mental health. So consistency is really important. Is pacing about gradually doing more? Is it scaling up what you're doing? Yes, we'd really like our patients to know that there's potential for improvement. We can't cure their condition, but what we want to do is minimise the burden of chronic pain on their quality of life. And the image in the centre is an athlete, and she's a really famous retired athlete in the UK, Paula Radcliffe. And I've put a picture of Paula here because I imagine all athletes have days when they don't want to train, and like patients, a bad day. And you think, I don't want to do anything today. I could just hide under my duvet. And it's doing something even when you don't want to, and just attempting something is always a starting point. I also think that Paula Radcliffe, this athlete, would be really flexible. And I really want pacing to be considered to be about being flexible with yourself, not necessarily how far you can bend and stretch, but just being kind to yourself. So if it is that you can't complete a task, you don't force yourself, you maybe just do it the next day. And there's that level of acceptance. Within the research, pacing is unclear as to whether it's helpful or not. And this really was the starting point for my research. So pacing ideally sounds to be helpful. But within the research, it's been found to be associated with better symptoms, but also worse symptoms of pain and fatigue. So in 2012, in a systematic review across patients with chronic pain, pacing was found to be associated with improved psychological function, but worse pain and disability. And that's not something that we'd encourage with our patients. Then in a large randomized controlled trial across patients with CFS-ME, pacing was found to be ineffective. So it was no more effective than standardized care, and it was less effective than cognitive behavioral therapy and graded exercise therapy. What's important about this study is they used a specific type of pacing, and they called it adaptive pacing therapy. And this is built upon what we call the envelope theory. And this really involves telling patients with chronic fatigue syndrome that they have a limited amount of energy, that they should work within it. So it's symptom contingent. And again, I discuss those issues of when we listen just to symptoms, when we work in order to stop or prevent symptoms, that actually it might not always be the most effective way of us managing our condition. In 2020, among patients with chronic fatigue, there was a systematic review with meta-analysis that showed pacing was associated with improved fatigue, but no improvement in physical activity and function. So really some take-home messages. So far, pacing appears to have the potential to be associated with improved psychological function and fatigue, more than perhaps physical function or disability. So pacing is actually a confusing coping strategy. There's different research findings regarding the effects of pacing. There's different pacing scales that have been used to measure pacing. And actually thinking about those studies that were highlighted in the previous slide, they only ever measured pacing according to going slow and steady, breaking down tasks, and taking rest breaks. So actually components that involve someone doing less. So it's perhaps unsurprising that it was found to be associated with disability. Those pacing scales didn't measure gradually trying to do more, trying to be more consistent, or maybe even accepting your condition of pain or fatigue. There's different aims of pacing. So sometimes pacing is instructed to patients with an aim of decreasing pain. And again, going back to symptom contingency, if you're advising someone to do something in order to reduce pain, the likelihood is they're going to be overly listening to their symptoms and they're going to stop before they get their pain. So again, encourages fear avoidance. Or is the aim of pacing to improve function, to gradually try and do more? So is pacing about doing less or doing more? Is pacing symptom contingent, doing activities according to symptoms, or quota contingent, doing activities according to an amount, a time, or a goal? There's also no agreed definition of activity pacing. So pacing instructions vary across healthcare services, professionals, researchers, patients. There's different approaches that have been used for different conditions, and there's no framework to ensure that the instructions of pacing are evidence-based. And this brings me on to the first stage of my research during my PhD. I developed an activity pacing questionnaire as a scale to measure those different components of pacing. In order to capture some of those different components, we used mixed methodology, and this involves using quantitative and qualitative research methods. So we developed the scale items using a consensus method called a Delphi technique, and 42 healthcare professionals completed 3 rounds of questionnaires about what should be included in our scale. We analysed the items in the scale using statistical methods from data collected from a questionnaire study. And we explored how acceptable the questionnaire was for patients by interviewing them on their opinions on how easy it was to use. And the results were we had 26 items in our scale, and they showed different facets of pacing that aligned with 5 broad themes of pacing. And they included adjusting activities, like breaking down tasks, planning activities, thinking about being consistent, acceptance that some activity targets need to change, and also progression. And for those who are interested in reading a little bit more about those psychometric properties of the activity pacing scale, I have a reference here that links to my paper. As an example of what the scale might look like, and examples of items for those themes, for the theme of activity adjustment, a scale item might ask a patient if they broke up tasks into periods of activity and rest, and they rate their answer on a 0 to 4 scale of never did this or always did this. For activity consistency, a scale item might be, I did a similar amount of activity on good and bad days. For activity progression, I gradually increased how long I spent on my activities. For activity planning, I set goals that were meaningful for me. For acceptance, I changed my activity targets if they were unrealistic. And what we found is that different themes of pacing were associated with different outcomes. So the theme of activity adjustment was associated with worse pain and worse mental health, whereas the theme of activity consistency was associated with improved pain, function, and mental health. So it's really important that we select the appropriate theme of pacing according to our patients' needs. For my postdoctoral research, I developed an activity pacing framework for chronic pain and fatigue, and this stood as a guide for healthcare professionals to standardise how we instruct pacing, so it's the most helpful coping strategy it can be. The first stage of this study was to gather opinions using an online survey of pacing, and this involved 92 healthcare professionals, including physiotherapists, occupational therapists, pain specialist nurses, doctors, and psychological practitioners, all based in the UK. And from here, we developed the first draft of the framework, and we tried to refine the framework using a consensus meeting. So a meeting between 6 healthcare professionals and 4 patients to talk about what really should be included in the framework. We then tested the framework in the clinical setting in what we call a feasibility study, and we also explored how acceptable it was. And the framework now includes specific aims of pacing, components of pacing, stages, and a new definition of pacing. And this slide shows some of those helpful aims of pacing, including reducing flare-ups, improving mood, achieving meaningful activities, increasing self-efficacy, managing symptoms, changing activity behaviours, reducing fear avoidance, reducing disability, developing flexibility, and increasing activity levels and functions. And what our participants in the research study found unhelpful was when the aims of pacing were to prevent symptoms or to conserve energy. Because when patients aimed to do this, we found that they were more fearful of activity and they gradually did less and less. And again, that reminds us of that cycle of fear and pain and avoidance. Some of those specific components of pacing are illustrated here, and they include some of those components we talked about on the slide with all of the images. So breaking down tasks, spreading out activities, finding baselines, setting goals, having rest breaks, being consistent, undertaking some activity despite symptoms. This is really important, doing something on a bad day, not overdoing on a good day. So we're reducing that boom-bust cycle, acceptance of current activity levels, allowing flexibility, setting realistic goals, gradually increasing activity levels of variety. We also propose 7 stages of pacing. We feel it's important to introduce pacing to our patients in the context of those other maladaptive behaviours. And what we find is when we illustrate the boom-bust cycle, excessive persistence and avoidance, patients often look and think, yes, yeah, I can see which behaviour I fall into, right? Yeah, I can see where I'm going wrong. We then talk about finding baselines, so what's achievable most days. We adjust activities accordingly. We use planning. We aim to reach more consistent levels. It's important to learn from the things that have worked well, the things that aren't working, and then progress. And on the screen, I'm showing you there the new definition of pacing that we developed, and I'll give you some minutes just to read that. And to pull out some key points from this definition, because it's quite a long definition, the aims of pacing are included there: to improve overall function, satisfaction with activities, whilst also managing symptoms. We also have included some key themes of flexibility, choice and control, which we know are really important with pacing, and perhaps contrast some of those previous pacing definitions and previous pacing research when pacing has been overly prescriptive and very rigid, and patients haven't been able to incorporate it into their day-to-day life. And the definition and those stages of pacing are reported in this research paper. And this paper shows the consensus meeting between patients and healthcare professionals. And I'm also showing you this quote from a patient who participated in the study. For me, what I love about this quote is the patient is really taking back control. And as a healthcare professional, this is ultimately what you want. We want patients to feel empowered, to be able to take control of their own medical condition so that they can manage it for the long term. Some of my research successes. For both my PhD and my postdoctoral work, I have fulfilled my study aims, and I've developed an activity pacing questionnaire and framework that appear usable and also acceptable. I've also been able to recruit to target, and I've been overwhelmed by the response by participants. I've also been able to engage stakeholders with varying opinions, so including both clinicians and the patient voice. I've had huge opportunities through my research fellowships. I've been able to travel to present at Vienna, Copenhagen and Geneva. I've also been able to work with research teams and to gain the knowledge from my research mentors, including Professor Linda McGowan. I've also attended training in research methods. Some of the timescales are huge challenges to any researcher. It takes such a long time to prepare a research protocol, to apply for ethics, to recruit patients, to collect the data, to analyse the data. Then to write up the research findings and to have them published is quite a time-laboured activity. There is a question whether chronic pain and chronic fatigue syndrome should be treated using the same approach. We've always treated them together due to those overlapping conditions. We know that many patients present with more than one condition. We also know there's a massive overlap in symptoms, but for some professionals and patients, they feel they should be treated differently. There's an ongoing conversation about whether we should use quota contingency or symptom contingency. For my pacing work, we follow quota contingency. We know we're thinking about chronic conditions, and we know that with chronic conditions, the amount of pain doesn't always represent the level of harm. And what we want to do is reassure patients and to build their confidence. However, we use quota contingency with flexibility because we know that patient symptoms vary and they might set themselves a goal, but on a specific day they can't meet it because their symptoms have gone up or they're having a flare-up. So they need to show flexibility too. We also think there's a place for symptom contingency, and in the acute setting, we think listening to symptoms is important. For example, if someone had broken their leg, then those signals of harm, the warning signals, are really important. We need someone to probably not walk on that leg, but to seek help instead. The activity pacing questionnaire and framework have only been validated in English, and they do require further validation before they can be used. So our future research involves to develop a culturally sensitive pacing resource for the framework and the questionnaire. We'd like to develop it in different formats and languages, so paper and digital formats. We'd like to use the activity pacing framework and the questionnaire in a randomized controlled trial to assess the effects of activity pacing, to try and gain some clarification into what is currently quite a confusing strategy. We'd also like to validate the pacing framework and pacing questionnaire for wider research and clinical use. I'd like to acknowledge my research mentors, including Professor Linda McGowan, who's here today, and also acknowledge my funders, Health Education England and the National Institutes for Health Research. And I'd welcome any questions. I do have, if anyone's interested, references included there as well. But thank you so much for your time.
We couldn't hear you clearly, Miss Usi.
Is that clear right now?
Oh, I can just hear you.
Okay. Thank you, Ibu Debbie, for your presentation. Before we go to the Q&A session, may I summarize what you have explained to the audience first? Okay, thank you. Jadi, kalau boleh saya simpulkan yang disampaikan oleh Ibu Debbie tadi tentang peran dari fisioterapi dalam perubahan perilaku untuk nyeri atau kelelahan dengan kondisi kronis, itu tadi juga sebelumnya disampaikan di awal bahwa sebagai pengantar, Ibu Debbie menyampaikan bagaimana kerja fisioterapi di UK atau di sini. Yang menarik itu adalah tadi ada yang namanya career progression atau perkembangan karir. Tadi ada mereka itu akan bekerja di National Health Service atau pelayanan kesehatan nasional dan juga bekerja di swasta atau mereka memiliki klinik sendiri. Nah itu mungkin untuk yang tadi band career progression band 8A untuk Ibu Debbie tadi 78A itu adalah berhubungan dengan bekerja di National Health Service. Kemudian untuk selanjutnya untuk yang tentang pain dan fatigue sendiri yang berhubungan dengan research-nya. Jadi untuk nyeri itu ketika kita merasa
Suaranya hilang, Miss.
Suaranya
Karena kayaknya ada trouble dengan entah dengan mikrofon atau
sekarang sudah ya Bu?
Bisa terdengar tapi agak bengong ya.
Coba saya sekarang mungkin Bu sudah jelas?
Lebih jelas.
Oh, oke.
Iya.
Maaf. Jadi untuk nyeri sendiri tadi ketika kita merasakan satu nyeri di area tubuh kita, pasti nyeri yang lain itu akan terasa. Misalkan seperti nyeri pada bahu, kemudian kita akan merasakan lain pada nyeri di area leher. Dimana yang namanya nyeri itu sendiri ada 3 kondisi, ada akut, subakut, dan juga kronis. Kalau yang akut itu adalah kurang dari 6 minggu, yang subakut itu adalah kurang dari sama dengan 3 minggu, yang kronis itu lebih dari sama dengan 3 bulan, yang dimana itu kesemuanya dapat mempengaruhi dari tubuh kita secara biologis, psikologis, dan juga sosial. Untuk yang akut itu kita pasti akan merasakan nyeri yang tajam, kemudian nyeri yang tiba-tiba. Di mana yang akut itu di situ nanti akan ada tissue healing process gitu, dan juga ada adaptive response yang dimana di situ akan mempunyai warning sign. Contohnya itu saat misalkan ketika kita mengambil sesuatu, tadi kalau dicontohkan oleh Ibu Dewi, mengambil sesuatu yang panas, kita akan langsung merasakan saat itu juga merasa panas gitu. Tapi untuk yang kronis itu nanti rasanya akan subjektif gitu, tergantung dari setiap individunya sendiri. Jadi kalau misalkan kita akan merasakan nyeri yang tinggi itu karena kita merasa kondisi yang gawat gitu, atau keadaannya sedang dalam bahaya. Jadi seperti tadi dicontohkan bahwa misalkan ketika anak kecil jatuh, itu pasti si anak itu akan melihat ke ibunya tergantung ekspresi dari ibunya. Kalau misalkan ekspresi dari ibunya itu kaget, kemudian merasa kasihan pada anaknya, pasti anaknya juga akan merasa yang dia sakit gitu. Tetapi kalau ibunya enggak, ya pasti anaknya juga tidak akan merasakan yang seperti itu. Maka tadi dikatakan the more attention to pain, the more brain work gitu. Jadi mental itu mempunyai korelasi dengan pain, tetapi pain ini tidak selalu sama dengan yang namanya harm gitu. Contohnya itu pada kondisi osteoartritis, jadi ketika tissue damage-nya tinggi, tidak pasti pain-nya itu tinggi, bisa jadi pain-nya itu rendah. Kemudian juga ketika kondisi phantom limb pain, jadi ketika setelah diamputasi tidak ada kakinya, otak itu masih merasa kakinya itu ada, sehingga si pasien itu akan merasakan gatal di kakinya, akan merasakan nyeri di kakinya, padahal di kakinya itu sudah tidak ada. Gitu. Makanya kita memerlukan yang namanya warning system. Kemudian tadi juga berhubungan dengan chronic pain, itu ada coping strategy, di mana coping strategy itu adalah di mana coping strategy itu nanti akan berhubungan dengan activity pacing gitu. Jadi activity pacing itu kita harus melakukannya dengan yang slow and steady, kemudian kita juga harus memiliki jadwal agar bisa menurunkan nyerinya. Kemudian kita harus ketika kita sudah memiliki jadwal, kita harus konsisten dengan jadwal itu gitu. Kemudian tapi jangan sampai kita itu memaksakan diri. Seperti itu. Kemudian untuk dari efek pacing-nya itu sebetulnya dia bisa untuk meningkatkan psychological function, tapi juga dia bisa meningkatkan fatigue juga, sehingga itu akan membingungkan. Nah, sehingga dari Ibu Debbie ini membuat research terkait dengan penelitian kuesioner tentang peningkatan activity pacing. Gitu. Jadi juga nanti juga akan melakukan research juga tentang mengembangkan dari activity pacing gitu. Tujuannya dari activity pacing sendiri itu tadi ada untuk meningkatkan mood, kemudian mencapai aktivitas yang memang meaningful, ada artinya, kemudian memanage dari simptom gejala nyerinya itu, kemudian masih banyak lagi. Dan juga tadi muncul juga untuk definisi activity pacing yang baru sendiri dari Ibu Linda. Jadi memang activity pacing itu dia merencanakan sebuah aktivitas, menetapkan tujuan yang dia itu berarti, kemudian secara bertahap itu akan meningkatkan aktivitas. Begitu mungkin yang dapat saya simpulkan. Jika ada pertanyaan mungkin bisa langsung ditanyakan dari teman-teman. Oh, sepertinya ini sudah ada satu pertanyaan. Okay, we have one question from our YouTube channel. This is from a student. How to differentiate between the incomplete and complete tissue healing to be stated as chronic pain? Can we categorize the chronic pain just from the onset?
Okay, let me know if I've not answered the question at the end. So we often talk about timescales in terms of tissue healing. So often if we think about soft tissue or bones, we know that they actually knit back together, scar tissue forms, and that process is often complete within 6 weeks, sometimes 8 weeks. So those timescales are guided usually by tissue healing. So we know that by 3 months, any tissue healing would then be complete. And if we also imagine when we first start feeling pain, there's also an inflammatory response. So we're also thinking about the inflammatory response having also settled down by 3 months. But then what we do see in the research is that because patients, if they're still in pain after 3 months, they might still show levels of stress within the body, which are associated with inflammation. But yes, we pretty much define it according to timescales in terms of when the tissues are likely to have healed. We also know that for chronic pain, patients may have an onset of pain without initial injury. So it might not be that necessarily they've broken a limb and then that limb's healed. Often patients describe more of a gradual onset of pain, and sometimes there's no known cause behind that. And we call that primary chronic pain, really. It's an onset of pain, and we're not quite sure why it's going on, as opposed to secondary pain. So someone might also have long-standing pain, but perhaps it is related to a primary condition of arthritis. So there might be a disease process ongoing within that arthritic joint. But as we said before, the real confusing point about pain is the amount of pain you might be in doesn't even directly correlate to the amount of tissue damage or joint damage we might see. But hopefully, to answer your question, they're standardized time points that we regard in terms of healing of tissue. But we know with pain, there may or may not have been initial tissue healing, tissue injury, sorry.
Okay, thank you so much for the answer. Okay, there are two questions more. The first is there any return to exercise guidance post COVID-19 programs that can be applied to communities and individuals? Could you suggest to us some of the guidelines?
We, within the UK, actually have government guidelines, and often our guidelines are published by what we call NICE. It's the National Institute for Health Research. And this governing body look at lots of different research and pull together the best known evidence. And currently, the evidence for us within the UK states that all adults should be doing 5 lots of 30 minutes physical activity or cardiovascular activity where you get your heart rate up. But they also suggest that adults need to be undertaking 2 sessions of strengthening exercise. And we know this is a problem as we get older, actually less and less people do strengthening. And then we have issues, especially among females, postmenopausal females with osteoporosis. So our guidelines within the UK very much recommend quite a formulaic amount of exercise per week, so 150 minutes. those guidelines, although they are produced for the UK, they are based on research evidence. So I wonder, I don't know whether there's something equivalent that you have, or whether those recommendations might still be helpful for you. There's generally guidelines towards the benefits of movement and exercise and activity for specific conditions, and also guidelines and research towards low back pain. There's been some really fantastic publications in the Lancet. There was a Lancet series, they called it For Low Back Pain, and really spoke about the global disability associated with back pain, and really encouraged coping strategies and exercise as key components to the management of those conditions. So if it is that you can't find specific guidelines that are relevant to your local area, there's an awful lot of research that will speak about the benefits of activity, and certainly the Lancet's back pain series has been really useful.
Okay. And since the time is over 80 minutes, we have one question for the last question. Last March, there's some hype issue on the Guardian about GET and long COVID. Here they recommend GET to long COVID patients because there's no study talk about the negativity effect GET on long COVID patient, but many clinicians, either physicians or physiotherapists, against it because the long COVID symptoms kind of same with CFS or ME. I'm curious on how CSP clinicians or physiotherapists on academic field handle this kind of issue, and about the NICE guidelines about rehab program. Do physiotherapists take a part on it?
Yeah, what a great question. It's something actually I've been chatting about with my work colleagues in the pain service for the last week, so very relevant to our service too. Within our pain service, we've actually been asked to start seeing the patients with long COVID. The patients who have come through the hospital with long COVID, they've almost been divided into two groups. Those with predominant symptoms of breathlessness and chest problems, they will be seen by our colleagues in the pulmonary rehab department. So the respiratory physios will work with them. And actually they will encourage them towards graded exercise therapy, the GET, but monitor their respiratory symptoms. Within the pain service, we've been asked to see the patients with long COVID who have predominant symptoms of fatigue. And the NICE guidelines, they've been very good at publishing a new guideline and defining long COVID to share similar features of pain and multi-system effects. What they're very good at doing is clearly saying this isn't CFS ME, and we're unsure about the disease process for long COVID. The research is also new, so it's literally occurring as we speak, and I think that's the real difficulty in knowing how to manage these patients. For us, when we start seeing the patients with long COVID, and I think differently to maybe when we see patients with CFS ME, we will actually be looking at oxygen saturation. So there will be something that we'll be monitoring as we're encouraging some movement and exercise. I mentioned before that real confusion about quota contingency and symptom contingency. With our patients with long COVID, I think we are going to need to be more symptom aware, because we know that actually these patients really suffer with shortness of breath or fatigue, and they get these real relapses and remissions in symptoms. So I think we're going to have a more quota contingent approach with a symptom awareness is how we'll approach it. But yes, the person asking the question has a good knowledge, because those patients with CFS ME, there has been some mixed research findings. There was a Cochrane review endorsing graded exercise therapy, but there's also been other research from patients finding graded exercise difficult So really, it's such a challenging area when we're working with long-standing symptoms of pain and fatigue. It's very difficult to hit that right balance of encouraging someone to be able to do something, to be able to be functional, because we know that impacts on their physical and their mental well-being, but it has to be at a sustainable level. And for patients with CFSME, and for those patients that we'll start seeing with long COVID, that's always going to be on the forefront of our minds. So yeah, a really, really great question.
Can I just add to the audience that there's, as Debbie said, we're all in a pandemic at the minute, and COVID is causing effects across populations, including some work that Chesa and Dari and I are doing about pregnancy, effects on pregnancy and birth. But also there's a study that started in the UK, funded by the Department of Health, which is looking at long COVID and monitoring it. And one of the authors will be Carolyn Chu-Graham. So if anybody's interested in long COVID, Carolyn Chu-Graham, who's a GP colleague of ours, but also a professor of primary care at the University of Kiel, her work is very relevant to long COVID for those that are interested. Thank you.
Okay, thank you very much for a wonderful answer. Jadi tadi dikatakan kalau memang pada pasien dengan long COVID memang tetap harus diperhatikan dari saturasi oksigennya dan juga kondisi umumnya, karena memang pasien long COVID ini mereka betul-betul suffer, dari mereka betul-betul sedang fight dengan COVID-nya itu sendiri. Jadi tadi juga dikatakan oleh Ibu Profesor Lida bahwa memang ada profesor yang maaf tadi saya kurang jelas namanya, melakukan research tentang long COVID itu sendiri. Gitu. Oke, apakah masih ada yang ingin bertanya? Ada yang ingin berdiskusi mungkin melalui chat di Zoom ataupun di YouTube? Sepertinya sudah tidak ada. Kalau sudah tidak ada, kita tutup. Okay. Thank you very much, Ibu Debbie, and also Ibu Linda, for this delightful Stadium General. We have learned so much from you this day. I hope what we had already learned can be implemented in the physical therapy service. Okay, ladies and gentlemen, we are catch up in the last session. It's a closing. Ladies and gentlemen, before we close.
Okay, sorry.
Before we close our Stadium channel today, let us say Alhamdulillah together. Alhamdulillah. Thank you very much for your participation today in this Stadium channel. I hope you enjoy the program and stay healthy. Thank you, Ibu Linda, Professor Linda, and Ibu Debbie. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi. Thank you very much, Ibu Linda. Thank you very much, Ibu Debbie. Such a wonderful presentation and session. Yeah.
Very, very enjoyable. Thank you for the invite.
Yeah, no worries. Yeah, I hope we can have another session in the future. Yeah.
Thank you.
Thank you very much. Yeah, have a good day, everyone.
Can we take a picture?
Oh yeah, yeah. We should take a picture.
Yeah. Teman-teman yang belum on kamera mungkin bisa on kamera dulu. Kita mau ambil foto dulu sebelum kita. Ya, oke. Kita mulai dari slide yang pertama. Layar yang pertama. 1, 2, 3. Okay. The second screen. 1, 2, 3. Okay. The third screen. 1, 2, 3. Fourth screen. 1, 2, 3. And then the last screen. 1, 2. Okay, thank you very much.
Thank you very much,
Okay, thank you.
everyone. Yeah.
Thank you so much.
Bye. Take care.
Bye.
Take
Bye,
care.
everybody.
Take care, Debbie.
Yeah, stay healthy, everybody. Bye.
Yeah, thank you.
Bye.
Terima kasih Bu Dika, Bu Fitria. Terima kasih.
Terima kasih Bu Cesa, Bu Fitria.
Oke. Izin live. Selamat menyiapkan hidangan berbuka. Sama-sama Bu. Selamat persiapan untuk berbuka ya Bu.
Oke, terima kasih.
Oke, Assalamualaikum. Mbak Usi, terima kasih Mbak Usi.
Terima kasih banyak Ibu. Maaf Bu.
Enggak, udah bagus. Terima kasih. Assalamualaikum.
Waalaikumsalam.